I'm grateful to the IAS for inviting me to present this on behalf of the National AIDS and STI Control Program with the program manager, Dr. Stephen Isiadu, who is here. I'm putting policy into practice when it comes to differentiated service delivery. What has been our experience after having developed our policy into implementing differentiated service delivery? Ghana's population, just by way of background, is about 29.6 million. On 23 million hectares of land. That's not too big. And we have 51% female population with a total fertility rate of 4.2. We are 51% urbanized, and 66% of women are literate as compared to 82% of men being literate. And 1 in every 24 infants die before 1 year. 1 in every 17 children die before 5 years, so we have a lot to do. Our first case of HIV was reported in 1986, and since then, in 2017, when we last had our HIV Sentinel survey, the antenatal care prevalence was 2.1%. In the general population for 2018, it was estimated that the HIV prevalence is 1.64%, and at the time, the estimated HIV population was 316,000, with children forming 26,700. New HIV infections in 2018 were about 17,600, out of which children formed 2,500 of them. And then almost 12,000 annual AIDS deaths occurred. Deaths from HIV-related illnesses occurred in 2018, out of which 2,473 children were part. Ghana has an HIV prevalence that is generalized. It's a low prevalence, but is generalized in the population. Our MSM prevalence is 18.1%, female sex workers 6.9%. We have about 9,000 health facilities, out of which 488 provide comprehensive HIV care. Our PMTCT sites, we have about 4,000, out of which 1,500 almost provide antiretroviral therapy in addition to HIV testing services. So how did we start with DSD policy development, implementation, etc.? In February 2017, we were supported by EQUIP, that's the National AIDS and STI Control Program, to do a facility assessment in 5 regions where we visited 20 facilities, and we wanted to find out what's the baseline, where are we going to start from? Because there's some form of DSD going on, even though it wasn't captured under that heading DSD. So what is available and where do we go from there? But at the end of it all, we realized that we needed to push differentiated service delivery in Ghana. So we focused on facilities that have at least, currently in our implementation, that have at least 200 clients or more, which comes to about 330 facilities who are our focus for now before we scale up to the other facilities. So after the assessment, we had a workshop with stakeholders, which included KP populations, our donor partners, etc., and implementers from the regions. And then we also had the support of a WHO consultant to develop this manual, which was ready by 2017, and then we had a task team. So the differentiated service delivery manual, which is on the WHO website, that's a picture of it. It covers the whole continuum of care from testing through to viral suppression, and differentiates among the general population. We have key populations covered there: children, adolescents, pregnant women, and men. So everyone is covered. And we have SOPs and algorithms to guide the process. So these are excerpts from it. I'm focusing on ART delivery for stable clients. So we have our definition of a stable client, which is adapted from the WHO definition. And then when it comes to DSD ART refill for the stable clients, we are looking at 6 months refill. So 6-month clinic appointments with 3-month refill. So if you can't get your full 6 months, you are given the opportunity to come for a fast-track refill at 3 months. The other opportunities we have for ART delivery, most of our services are available in the facilities, but we have the community-based health planning and services, which are the lowest point of care for healthcare in Ghana. And the nurses manning these often go out on home visits in the community. So in so doing, when they are visiting the homes, they are also able to deliver antiretroviral therapy to the clients. So we have community-based individual facility ART delivery. And then when it comes to the delivery, we are looking at engaging lay cadres in the 1 million community health worker project. That is ongoing, but it's not fully rolled out now. So we have, as part of our SOPs and algorithms in the manual, the summary of the clinical and refill visits to guide facilities. And then also, when it comes to the fast-track refill, what goes into it? We have the building blocks, the when, where, what, who, in there. And then the standard operating procedures for group facility-based ART refill. That is when we mature to that point, what to do. So everything is covered there until we are actually implementing. Then there's also the SOP for health center, CHIPS, community pharmacy refill. So the drop-in centers are also going to be part of this as we roll out DSD in Ghana. So how did we prioritize our implementation? I already mentioned that we are looking at facilities with at least 200 or more clients, and we also want facilities to have an experience. We want a lot more people in the facilities to have an experience of DSD, to come to understand HIV care. So we are not doing the classroom training, but on-site training. We are working with the regions to implement this. Currently, we've covered about 30 facilities on our own, and EQUIP has also covered 20 facilities. What has been the gain since we started differentiated service delivery? Our facilities, at least up to 60% of our facilities are now doing multi-month scripting and dispensing, and approximately 60% provide 6-month clinic consultation with appointments. And then the community-based individual ART delivery is done by about 30% of facilities. Our main challenges have been time lapse between development of manual and rolling out the program, just because we had funding challenges. And then also, after we oriented our regional teams, there was a time lapse before this was done in June, and then we actually started the rollout in December, so we had to do some refreshers for them. And the online strategy is pretty time consuming, but it meets the needs of the facilities, which are facility specific. And then availability of commodities, making sure that ARVs are available at the ART clinics and at the pharmacies. Communication provision for loss to follow-up tracing is vital. You know, currently we don't have a national system for tracing clients who are lost to follow-up, not just for HIV, but for any other condition. So as part of differentiated service delivery, we make this available, and facilities, some of whom implementers are here present, will testify to it, that they've been able to call back on a lot of patients who have come back. Some said they forgot they had to come back, all sorts of reasons. Some were looking for a cure, but the call encouraged them to come back. And then they were also able to find out those who had died. So our M&E tools are not yet part of the national pack, but we still have developed them, and we have to emphasize that there's a need for supportive supervision. What have we learned? Stakeholder engagement is important. Funding, we should have a costed plan and dedicated funding before differentiated service delivery can be rolled out. It is not a new thing entirely, but as we are renting facilities, we need to make them understand they need to document certain things they were not documenting, even though they were doing them. That is why we need to have good funding for that. And then procurement planning, and then make sure that our indicators are better monitored, especially developing process indicators. And then supportive supervisory visits is a must. Once you have oriented them and you leave them, after 2-3 months, we need to go back to find out how they are doing. I would like to say thank you to all our global partners, and thanks again for the opportunity.